devastating news to hear that a woman has passed away during labor. But a lot of people usually have misconceptions around why this woman died and how it was possible. That is why on this episode of the Maternity Show with me, Sona Dabo, on African Renaissance TV, today we'll be looking at the overview of maternal mortality in the Gambia, of course with Dr. Musa Maren. Doctor is a gynecologist and he's also the head of the Rampa unit of the Ministry of Health in the Gambia. Doctor, you're so much welcome to the Maternity Show.
Thank you.
We want to really understand a lot of issues around maternal mortality today in the Gambia, because people, not just in the Gambia, but across the world, always fear, when a woman gets pregnant. And this should be a joyful moment for every woman. Women should really be prepared to go through this, but instead of being happy, it's the other way around. So on today's episode, we want to understand what are some of the factors around these things. But before we go into the show proper, we want to understand the difference between maternal death, maternal mortality, and then pregnancy-related deaths.
Thank you, Sona. You have summarized it, that this should be a moment of joy for the couples, especially the woman, bringing somebody into this world. But unfortunately for some of them, they tend to either lose their baby or lose their own life, or both of them. And that has been happening since I think as long as man himself. It's unfortunate that worldwide this has always been a problem. Worldwide, if you assess, you will see that a woman dies from pregnancy or childbirth related issues every minute, and it has not been a recent advocacy that the society, the government should look at these issues so that we put women as the forefront when it comes to development. One of the former directors of WHO said women are dying from issues not because we cannot deal with the problems, but because society did not take it seriously, if I may paraphrase what he said. And when a woman dies, we see the end, which is the death. But along the way, there are things that we can do as individuals, as communities, as a people, as a country, as a government, so that we prevent this woman from dying. So in the Gambia recently, because of the issue of the social media, when somebody dies, you are able to get it within the same few minutes after the individual deaths. So that has raised a lot of issues, and we are happy that the awareness is there. People are now aware, because now society is beginning to care that our women are dying from childbirth. But what we need to do from there, knowing that this is what is happening, what we need to do as a society, as a country, is to come together and see what are the solutions, what are the way forward when women die. Yes.
So when can we generally say this woman has died as a result of maternal mortality?
Okay, so when we say a woman died from pregnancy, from pregnancy or pregnancy-related issues, what we basically means that the woman who died should have been pregnant. When she was dying, she should be pregnant, or she should have lost her pregnancy, and the duration of the loss of the pregnancy, the standard days is 42 days, which is 6 weeks. That's what we consider as maternal death, and the death should be related to the pregnancy or the complications of the pregnancy or its treatment. The death should not be related to an accident, example, a car knocking a pregnant woman on the road, or a pregnant woman falling from a height, or any incident or fire outbreak. Those ones are not counted but as maternal death. The ones that are really counted is this woman is pregnant and has developed complications as a result of the pregnancy or its treatment, or or from pregnancy itself. So that's what we consider as a woman dying from pregnancy. You've said two issues, pregnancy-related death. The difference between the two is the duration. In pregnancy-related death, the duration is 1 year. In other countries, it's 6 months. So that's the difference. So if the duration is always the difference. Yeah.
Nice. So looking at that definition for maternal mortality and then pregnancy-related death, what would we examine as the trend of maternal mortality in the Gambia for the past couple of years now?
Yeah. So maternal mortality, or we say maternal death, the mortality is a ratio. So if you are saying mortality, then you will say the ratio. But if we look at maternal death itself, there is what we call direct causes of maternal death, which means that the woman is dying as a result of pregnancy itself, which means that if this woman wasn't pregnant, she wouldn't have died. Okay, there are others who might have had other issues or developed certain diseases during that pregnancy which are not related to the pregnancy, but because of the pregnancy the disease becomes very serious and severe, so they died as a result. Those ones are the ones we consider as indirect. For example, if you have a malaria and you are pregnant and you die from the malaria, so we'll call that indirect maternal death. Or you have TB, or you have HIV, or you have anemia, the basic things that any individual can have who is not pregnant can also die from. So if you have those conditions and it becomes complicated and you die while pregnant or immediately or within 42 days of delivery, we consider it as indirect causes. In the Gambia over the years, the trend of maternal mortality or the ratio has been going down. If you look at around, let's say 1993 or even 1973, it was in the thousands. So when we say the mortality ratio, what we mean is for every 100,000 babies that are born alive, this number of women would have died. So the ratio, when I say it's in thousands, it means that 1,000 women would have died for every 100,000 babies that have been delivered alive. So it was in the thousands up to 2013 when the data shows that it was 433. The latest data, which was 2019, shows that it is 289. So if you look at the data, the trend, it is going down. But what you and I or everybody else would like is nobody should die from pregnancy. So that 200 and something dying every year is high. Naturally is high. In other countries they are in one single digit. We are in the triple digits, and the Millennium Development Goal, which now become the SDG, is saying that it should be about 73. So if you compare what that is saying, it means that we still have a long way to go to be able to achieve the Sustainable Development Goals as a country, to get to the 73 that is required as a country. But if you look at our country relatively from what we were before, which was in the thousands, now we are in triple digits and is almost at the end of the triple digit. I think we have gone a long way, but that's not good enough.
We still need
a lot of things to
reduce down the number, because I realize in 2030 we are looking at a quite fewer number, like 70 for every 100,000 deaths. So in response to that, to the SDGs, what policies and interventions do we have from the aspect of government?
Yeah, so if you look at the SDG, it cut across all sectors. It's not only about health. Health has two components, or two goals to achieve. If you look at reducing maternal mortality and reducing the infant mortality, there are others that are also health related, but not totally health related. So if you look at the SDG, we should reduce the ratio. In reducing the ratio, there are things that we need to do. That means we need to increase the number of skilled providers as well. We also need to when it comes to infant mortality, also we also need to reduce it. So there are things that that we need to do. But as a government, you will have to take the SDG as a whole package. And in relation to maternal mortality, a woman usually doesn't just come and just die like that. There is what we call the road to death, meaning that the woman would be walking along this road, which is usually a straight road as you are going, but along the route there are always exits. And one of the most important exits in this is education. We need to educate our women and boys as well. As a child, we need to make sure that they get educated. An educated woman is an empowered woman. An educated individual is already empowered. So which means that she will be able to become a skill provider, either be a doctor or a midwife. Two, is able to understand the importance of health.
That is the interventions of the government.
Yes. Yeah, so the interventions that government needs to do to be able to achieve this is not only health. You need to look at the broader aspect, meaning that the Ministry of Higher Education and Basic Education have a big role to play to be able to reduce maternal mortality.
We will come to like the key institutions.
The key institutions, yes. So if we deal with education, we are not saying that only health education, but the general education aspect of it is very important. When people are educated, they are empowered. There won't be early marriage, and they won't get pregnant when they are young, because they will have to go to school to be able to complete the school before they think of having a family, and they will be aware of spacing their kids. Proper nutrition will also be, because they are already empowered. They know what is good for the body. They may know what is good for the body. For the general population that probably would have gone over the age of going to school, we need to increase the advocacy, health education, awareness. These are very important. That's one sector of education that we need to deal with. Moving from education, meaning that education is one of the exits. If you educate the girl child, you will reduce the community maternal deaths. So the second aspect of what we need to do is immunization and nutrition. We need to make sure that our children are immunized. And if you look at the government's data, our immunization, the number of children that are immunized is almost 100%. For the first 2 years, our kids are being immunized. If you immunize an individual, you are protecting the individual from early childhood illnesses. Some of the illnesses we have eradicated, and those childhood illnesses can cause growth retardation. A child is always sick, so you will not be able to achieve your adult structure. So your bones will not have been able to develop well. You cannot withstand the intensity of pregnancy. So if you don't have that early childhood immunizations, you may be at risk. You may of having diseases. And also the immunization. Now we also have immunization of children, which is the HPV vaccination, which we are rolling out as a government. So the immunization aspect, we are dealing with that. The nutrition aspect, we know that we have a lot of traditions in this country, where pregnant women are advised not to take certain foods based on the traditions, like eating eggs, eating certain kind of foods, vegetables like bitter tomatoes and others. They are advised not to take that. So, but if we eradicate those food taboos, our pregnant women will be able to eat a balanced diet to be able to prevent anemia, because one of the commonest causes of maternal death is anemia, blood loss. So, and a pregnant woman would have to also have a lot of reserve to be able to withstand the intensity of pregnancy, not to have anemia during pregnancy. So that is very important. But aside that, as young people, when we all grow up in our families, we used to be told that kids are not supposed to touch anything on the food. So from that early age, you are deprived of the necessary nutrition that you need. So if we have people who are aware, and we allow our young people, especially girls, to be able to have the proper nutrition, their development and growth will be well protected. So the issues and the complications that they will develop in pregnancy will be less. So nutrition is one of the aspects that we need to deal with as a country. And agriculture, has a big role to play. The rice that we eat, or the quality of the rice, are our foods fortified with iron and others. These are things that we need to look at as a country to be able to boost the health of our population, because they always say prevention is better than cure.
So okay, we would want to classify these things as interventions that the government is doing to protect women from dying.
Yes, some of them government may not be doing it as well as they should be doing it. Okay. So these are the interventions that I'm trying to roll out, so that we all understand that it is not only the health that have a role to play, but everybody else have a role to play. Moving from that, immunization and nutrition, we also need to look at empowering our women, both in financial empowerment and decision making. Most of when we talk of financial empowerment, the women usually don't have their own individual incomes. So when issues arise, for example, the food they even would like to eat during pregnancy, they will always have to ask somebody, their partners, to be able to provide that. Even if they go to the market and they see something, they know that this would be good for my family, they don't have the capital to be able to buy some of those things. So empowering them, employing them, they will become financially independent. Providing job opportunities for them will prevent them from being taken hostage by their partners, by relying on their partners. The government, apart from employment, business opportunities for women. They should be allowed to venture into business, whether it is traditional business or farming or all those things. Even land, they should be empowered to get land. So these things are very important. When we empower our women financially, we are indirectly empowering them, because they won't be even able to pay for their schools, their kids to go to school. Education is very important.
Having collaborative efforts.
Sure. So if you employ a woman, whatever income that woman gets, is going to invest it back into the family, which would include the children that are coming up. So empowering them. And also the second aspect is the decision making. Generally in our society, women don't have control over their own body, which means that whatever is affecting them, they need to take permission from people to be able to decide whether they have the right to go and seek care or not. So that decision is always having an issue. You have a pregnant woman who would want to go for antenatal, or who even develop a complication, will have to wait for the husband to decide. Maybe the husband will not be the one to decide. It's the in-law who will decide, or not even the in-law, probably the marabo, or the health worker, or somebody, a trusted individual in the community, or even a community leader will have to decide that this woman would have to leave her home to go and seek care. So if we empower women to be able to take those decisions when they feel that they need to go to the health facility, they can go without any issues surrounding that. That will be very important. And even when you are supposed to provide them with service at the health facility, for example, a pregnant woman comes, is supposed to go for cesarean section, and you inform the woman that you are going for cesarean section, that woman cannot take her own decision whether yes or no. Will have to seek the consent of the husband, and the husband will have to seek the consent of his father or somebody else. So we have a lot of obstacles when it comes to decision making, because of the women are not empowered.
Okay, so before we go on a quick break, let's just get back to, let's say, policies around antenatal care services in hospitals. As your unit, the reproductive, neonatal, child and adolescent unit. So let's understand what policies are around antenatal care, because this is an important component to prevent maternal mortality.
Yes, I think as I'm flowing, I will get to the antenatal care. So if you would not mind, we will get there.
Maybe before we get to that, we will just take a quick break and then be back. Yeah. All right.
Thank you.
Just to remind our viewers that we are recording this episode at Badala, one of the finest hotels in the Gambia that you can always go to for all your bookings, especially during this holiday. You can always reach out to them and they will provide you with the best services that you can imagine. We will go on a short break and we'll be back. Welcome back from that short break. If you're joining us now, this is the Maternity Show on African Americans TV with me, Sona Adabo. And on this episode, we're looking at the overview of maternal mortality in the Gambia, of course, with Dr. Musa Marena. Before we went on that short break, we were looking at some interventions that the government should do or are doing about the prevention of maternal mortality. So we will just quickly try and explore the success in these initiatives that the government has taken so far to prevent maternal mortality.
Yeah, so when we look at education, because that's what we started with, when we look at education, we have what we call free basic education, including girls. So along the years from the previous government, we had what we call the PEGEM program, where there was free education for girls. That has also increased the girls' enrollment in schools. So that has helped us to move, probably even reduce this maternal mortality. There was no study done, but if you look at some of the interventions, you can somehow relate them to that. And along that way, you also have the university coming in. University of the Gambia, we started in 1999. And also they are training doctors and nurses. So if you look at the interventions of educations, I think that is something that government should be able to encourage, vocational trainings and other things, so that our women are empowered in education. And also we as healthcare workers, we have been doing what we call awareness during our antenatal for women who would have limited knowledge in healthcare, especially reproductive health. So we have to continue with that. And even this program that we have is one of the awareness that we have to continue to improve, because it's a cycle. You may have given awareness to this group of women, and they probably would have stopped giving birth now. So you need a newer group of people. So the awareness and the education, I think government needs to invest more, not basic cycle, but let's say up to 12 years, grade 12. That is something that they need to look at, and they also need to invest into tertiary education. There's a very good a chunk of the population that has been left behind. I always speaks about that. Our madrasa individuals, most of their education they have to pay. Is private. So the government also would have to look at that to see how, because whatever education the individual has, it increases the person's awareness. So if we also invest in those people, we bring into the society, because they will also reproduce, they will get pregnant, they die from maternal mortality. So those are things that we need to look at to be able to have every population. No one should be left behind. I think that is something that we need to look at. Moving from the educational aspect, we talked about the immunization, the free immunization for all children in this country, whether you are a Gambian or not, is something that government has been investing on over the years. That's why we have this higher number. And also we have what we call defaulter tracking that we do for people who have not been vaccinated. But the challenge we are having now is the anti-vaccine groups that are coming up. So we have those issues surrounding that. With nutrition, I may not have much idea what the Ministry of Agriculture is doing, but we also need to look at how do we promote local production and fortify our foods when it comes to be able to have food security. Is very important, from the food processing, the pathway from the production of the food up to the consumption level. Food safety and hygiene are very important. The other aspect that I talked about, or the last aspect, that empowering our women, we've seen that the government has established Ministry of Gender, basically empowering women. I think that is a good idea, but it should have gone beyond that. At the local level, the grassroots level, what is the role of the women? We've seen that women are taking positions in government, and they will be able to make decisions for their fellow women to be able to reduce the maternal mortality and morbidity. I think that is important. But the difficulty we are having now is the household decision making. How do we make sure that women are empowered to be able to make those decisions? And also the business opportunities, land ownership. We've seen that in the rural area, land ownership is male. Female usually don't have that. I think these are things that government should be looking at. But moving from there, we also need, we always forget the biggest component of this, which is male involvement. We need to involve the male because our society is traditional. Secondly, we are a religious country as well, both Christianity and Islam. And traditionally, men has always been the leader. Men are, they said men are the ones supposed to provide for the women, and also they are responsible for the woman. If you are responsible for an individual, you are also responsible for the individual's health. And if that health, you are not involved in it, you may not know what is happening. So we are always encouraging. We, as a ministry, we have in some facilities, we have changed the structure of the facility so that the men are able to be present while their partners are in labor. We also have what we call if a man goes with your partner for antenatal, priority is given to you, to the man. If you take your child as a man for vaccination, priority is given to you. So these are things that we are trying to encourage male involvement. And now we also have some facilities that conduct male clinics. So these are things that are geared towards involving men, for them to also understand. Traditionally, when women are in labor or pregnant, all women are the ones that accompany the women. So we want men also to come on board. The tradition can continue, but men needs to be involved in it. They should lead. They are the ones who will even know whether the woman is pregnant or not. They are in the same house. So if the man is not involved, or even encourage, or even go lead the woman to go for antenatal, it is always an issue. And even when the woman is giving instructions, they may forget some of them. But the man could be used as somebody who reminds: take your medication, sleep on the mosquito net. Did you do this lab? The doctor said 1, 2, 3 you should be doing. I think the doctor said this is the month you are supposed to deliver. Did you buy this? Did you do this? So the man would have understand all these issues. I think it is important that we involve the men. The men. That is important.
For everybody.
The other aspect we need to look at is what we call family planning. We've been saying what women are dying as a result of pregnancy. So if we want to prevent it, the first aspect of it is preventing pregnancy. Because if you don't get pregnant, you don't die from pregnancy. But I don't think that would be something that we can advocate for. But what we can advocate for is what is the meaning of family planning.
Yeah, I really want to have a whole episode on family.
Yeah, so let me just browse through that. Basically, what we meant by family planning is you are planning consciously how many children you want to have, exactly when do you want to have them, and at what interval. Even our religious aspect, the Quran mentioned, I'm not very vast in the Quran, but I am aware that the Quran mentioned that breastfeeding should be 2 years. How can you breastfeed your child for 2 years if you are not thinking about the intervals? And also it says that pregnancy is 30 months. If you look at 30 months, you subtract the 9 months from there, you are left with 21 months. 21 months is almost 1 year, 8 months. So if we encourage our religious leaders to be able to preach around this area, so that our people understands that we need to have intervals, because some people will get pregnant while they are sick. They will get pregnant frequently. They will get pregnant when they are young, and they will continue to be pregnant even at advanced age when they are 40 and above. And all those things comes with complications. So these are things that we need to consider. We need to look at. Move us to the next question. So we are now almost to that question that you're asking about antenatal. So you can ask your question.
So the question now would be, what we are now going to move medical, basically. What are some of the key factors that really affect pregnancy in the Gambia, or should we say what are the causes of maternal mortality in the Gambia?
In the Gambia, the common causes of maternal mortality is bleeding, hemorrhage, bleeding. We've recently also seen that high blood pressure is one of the commonest. And high blood pressure is linked to bleeding in many ways. If your blood is high, you may probably have a complication of your placenta separating prematurely. If that separation happens, you bleed. And because of high blood pressure, also your blood doesn't clot very fast. So, and that can, if you bleed too much, it can also affect your kidney. So you look at high blood itself can affect the kidney. It will cause bleeding, which can also affect the kidney. So in the end, you will have one person having 3 or 4 complications at the same time because of the results of one complications. So we've seen that bleeding is one of the issues. We also seen infections after delivery or after miscarriage. Not forgetting that if you have a miscarriage, it's also, and you die, it's also considered as a maternal mortality. It's not only pregnancy and delivery, but even if you have a miscarriage or ectopic pregnancy, these are things that also causes infection. In the past, we used to have obstructed labor, but because government has now improved our basic and comprehensive obstetric care throughout the country, WHO have recommended that you should not go, if you have a population of, let's say, 50,000, you should have one comprehensive obstetric care unit. And if you look at our distributions, in almost every region, we have one comprehensive obstetric care unit, which is functioning almost 24 hours. And also we have a relatively fair referral system. And also the government recently, I think last 2 years, has invested in community ambulance so that the delays that are happening along the way would be reduced and minimized.
Yeah. So would it be ideal to say that most of the deaths are happening from the regions? Do we have any form of disparities that are causing this?
No, not unfortunately, but expectedly, the regions are not supposed to record high mortalities or even deaths because they have the luxury to be able to refer to a higher level. So what we are seeing now is most of the mortalities are happening at the centers, the bigger centers, like the EFSTH Banjul, the Carnegie General Hospital, Bansang, and Farafenni General Hospitals, because these people will have to leave their community, move to the nearest health facility, then move to the major health facility before they get to the tertiary health facilities. So along the way, there are a lot of delays. So the flow will be easier if
could this be as a result of referral delays or also delays coming from the family or the society?
Yes, so basically, naturally, we have what we call 4 levels of delay, but most people will call it 3. So basically, the first level of delay is you having a problem, not realizing that you have a problem, which means that our women will be bleeding and believing that that is what they call the pregnancy is reducing. So in local language, they also call it talakan. My pregnancy is reducing. They don't consider it as a problem, so they don't seek care early. So they have delay in recognizing that it's a problem. They start convulsing. They relate it to witchcraft. They have high fever, they consider it as witchcraft. Swelling of the legs, they will say something, they have names for all these things. Dizziness and all those things, which is symptoms of anemia or high blood pressure. They don't know that these are issues that you need to go and seek care early. Or even they book very late for antenatal. I would have gone from there, from the family planning to antenatal care. So these are issues that we are challenged with. But if you look at our antenatal care itself, government has made antenatal care free. The service is free, and some of the basic elements of the antenatal care, because it's a package. The first package is you have the healthcare provider examining you, taking your story, that history taking, examining you and sending you for investigations. It's also they give you some supplement, and you are also given some preventive measures, which is immunized. You can be immunized, and also you are given anti-malarias. These are packages that our women are supposed to receive, and they are supposed to visit the antenatal 8 times if they don't have any issue. It can be more than 8, but basically it's 8 times, which means that the first 3 months, which we always encourage them to book very early. Sometimes you hear some men or some women saying that I'm pregnant, but I didn't know for 9 months. That is, those are things that we say that they don't even know the symptoms of pregnancy, because one of the commonest symptoms of pregnancy is missing your period. So you cannot be pregnant for 9 months and missing your period for 9 months. You didn't know that that is pregnancy. You didn't seek care. So these are the challenges. So in the first 3 months you come only once, okay? The second 3 months you come twice, and the third 3 months you come 5 times. If you go up to your 10th month, it may be less than that. It may also be only 3 times in the third 3 months. If you deliver earlier than 10 months. So these are things that you will be taught during the antenatal. So the antenatal service is free, and is one of the commonest causes of recognizing complications. The best area to be able to track a woman is during antenatal services. Those 8 times they are coming. The examinations that we do, these questions that we ask them, these treatments that we give them, these investigations that we do are geared towards recognizing complications, early detection. But if you don't attend antenatal throughout, or you waited until you are about to deliver, you attend antenatal, these detections will not happen. So these have been our challenges. Some of them will not even come regularly. Some of them will not take their medications. Some of them will not even sleep under the mosquito net that they have been told to do. And even the advices that you receive, what to eat, what to wear, what to do, and even the birth preparedness and complication readiness are things that they are taught during this antenatal period. But we have challenges of our women attending antenatal regularly.
Going to be
yes.
What challenges?
Yes, challenge. Yes.
For you.
Yes. So the challenges there for us is the service is there because we start from the health post, the community health facilities, primary. So for every health facility, almost every health facility in this country, both private and public, is providing some degree of antenatal care in this country. So which means that access is not a problem. Getting to these health facilities and receiving the service is not a problem. The problem that we have is the number of skilled providers that we have. The women, the compliance when it comes to attending or even taking their medications has been the challenges, and for them to recognize the danger signs have always been our challenges. And we are now encouraging women, men also, to attend the antenatal. These are interventions that we are doing as a country to be able to make sure that everybody is involved. It's not only the women. Yes.
Right. So I'm afraid we are quickly running out of time, but I wouldn't want to let you go without addressing something like this. So most of the stories that we hear from women that die usually narrate that it's as a result of negligence, let's say at the health facility level, and also probably as a result of lacking blood at some point. What would you have to say to this?
Yes. It's one way of there, one person saying one thing, and what the evidence are showing. What we normally do is when we hear some of these stories, we investigate. But I think there's one component that time wouldn't allow me to explain, which is emergency situations, which happens in our tertiary facilities. Example, a woman is supposed to have a CS. She's been asked to come to a tertiary health facilities. They may not come there. They will wait at home, go into labor, sit at home until complications develop. Go to the nearest health facility or delayed for a long period of time. By the time they get to the nearest health facility, which is not providing that service, then they will get an ambulance which will transport them for free to the basic facilities. You probably get to the basic facility, you find only one midwife and one doctor seeing 20-30 patients. That's why I said education, we need to look at how many people that we train. You get only one or two doctors, one doctor and maybe two midwives seeing 20 patients. and all of them are emergencies. So what we do is we triage them, we prioritize them, whose is more important than the other. Probably you have one theater, and you have 4 or 5 patients to operate. Then maybe electricity, there's no electricity supply. NAVEC has taken the electricity, or there's no water supply. Or over the years, you go to places like Brikama, they conduct about 50 deliveries in a day. So 50 deliveries in a day, obviously they will run out of resources and materials for that period. So, and if you look at our statistic this year, we are expecting to have about 85,000 deliveries. These are women who have carried their pregnancy to term, not the ones that will have miscarriages and other complications. But we are expecting to have 85,000 deliveries. If you look at the population of 2 billion people, 85 deliveries every year. That's huge.
Sure.
So there's a lot of pressure on the resources that we have. These things, unfortunately, do happen. But we are trying to mitigate some of these problems, to be able to train more people. We even started training doctors locally to specialized levels. We also are planning to introduce direct entry for our midwives, because what we have now as present is you have to become a nurse first before you become a midwife. So our plan now is directly from high school, 3 years you become a midwife, so that we have the necessary skills that we need as a country. So these are some of the steps that government are taking. They may be slow because of the rapid development and the resources are not available. Gambia is a resource-strained country, so donors, we have to rely more on donors to be able to get even the human resources. Unfortunately, the other side effect that we have we training people and they are going. Unfortunately, and we cannot provide them with the incentives that they may require to keep them, because we are a resource-trained country. So you train a lot of people, in the end, you don't get their services, because a lot of them would have left either the public service or they even left the whole country for other countries. So these have been the challenges. I think 1 hour is not enough. We can talk about this thing for a whole 2 days or 1 week. We won't complete.
Sure, we will definitely have you back on the show so that we can complete some of the questions we still have, especially around the factors of maternal mortality and how we as a society can contribute to stopping this rate that we have. But before we let you go, kindly share your message for the public.
My message for the public is we all have to be activists, but we have to be positive activists. The negative activism is you always seeing the negative. As a positive activist, what you do is you identify the problem and you find solutions and you work towards achieving it. You don't wait for somebody or calling on somebody to come and do something about it. In your own community, even your neighbor, or even in your house, how many times have you seen a pregnant woman and asked her, when was the last time you went for antenatal? When you went for antenatal, what did they do for you? So if you want to be an activist, it has to be positive. And how do you become a positive activist? Take care of your family, take care of your neighbors, take care of your extended family. If we all do those small things, it will become a big thing. So you and I, we hardly even talk to our family. We have our wives there. We have even our husbands there. Our brothers are there. Did we even call our brothers to ask them, have your wife booked for antenatal? I understand that your wife is pregnant. Have you gone for antenatal? So we should be caring. They said what caring is what? Something that sharing is caring. We need to share. Whatever knowledge that we have, we need to share. We should not start pointing fingers to one another. We need to call people who are responsible to be able to fulfill their responsibility. But we should do it in a civilized way. We should encourage people. We should motivate them. We should call them to order if they are not in order. As a people, if we do things civilizedly, we will be able to reach where we are aiming for without too much resources. All these things that I have said, how many of our people have even seen a child in the street who doesn't go to school? How How many of us are concerned that this child is not going to school, is not getting educated? How many of our people are eating in your house, throwing the remnants of the food? Have you given it to anybody? Even your neighbors? We don't. How many of us even concerned that there's a baby there? Is he going for immunization? How many of us are doing that? So I'm an activist.
Okay.
So I love activists. But what I don't like is negative activism. So we have to be real activists to be able to do some of these things. How many of us even encourage our partners? So how many of us tell their husbands that let's go for antenatal? Today we are supposed to go. He will tell you I'm sleepy. You will not have anything else to see. So if you want to be activists, we start with ourselves and our families and our neighbors, our streets, our coin. If we start with that, we will be able to achieve a lot of things.
Thank you so much, Dr. Marina, for honoring our invitation, and we really appreciate the wise words that you've uttered on this episode today. So viewers, that does it for us on this episode. The topic was on the overview of maternal mortality, and of course we had it with Dr. Marina. And then we did end up saying that this is a collective work, it's not one person's show. So we all need to be positive activists. We really need to understand why something is happening and then get towards solving it. So that brought us to the end of this very important episode, and we want to take your leave. But before we do, we just want to remind you all that this show is still open for partnership and sponsorship. Just to remind you all that we are recording this show at Badal Park Hotel, of course one of the finest hotels in the Gambia, and we are in December already, so you can do all your party events and bookings at this particular hotel so that they can give you the best services they have so far. Thank you.